name is Leonardo Jimenez Ribagorza, and it is my pleasure to present you a research that I conducted in collaboration with Dr. Ricardo Orozco, Dr. Marilena Medina Mora, and Dr. Claudio Raful, which address HIV-related stigma as a barrier to treatment adherence among men who have sex with men who use crystal meth in Mexico. To begin with this presentation, I would like to give you a brief introduction to the epidemiology of HIV in Mexico. From 1983 to 2021, a total of 327,260 cases of HIV were reported, of which 15,446 happened in that year. On the other hand, by 2020, 4,995 deaths related to AIDS were reported, of which 1,718 were new cases. This data shows that the proposed targets of UNAIDS for 2020 were far from being achieved. In Mexico City is the state that has the highest concentration of reported cases of HIV in Mexico, and it is known that the HIV epidemic in our country affects more men than women, especially men who have sex with men. Treatment adherence has been promoted to treat and control HIV, which is made up of two main sections. On one hand, there are pharmacological treatments that refers to the intake of antiretroviral, and on the other hand, there are non-pharmacological treatments, which refers to the behaviors that are not properly taking the medication, but that does affect the level of viral load and CD4 cells of the person. There is no gold standard for measuring treatment adherence. However, according to Censida, which is the entity responsible for HIV epidemiological surveillance in Mexico, a person adhering to his or her treatment follows all medical indications, both pharmacological and non-pharmacological indications, at least 95%. It's especially important to talk about adherence to treatment in this population because from this point on, people living with HIV can reach an undetectable serological status so that the natural chronic progression of the infection stops and the risk of transmission becomes null. Given the importance of treatment adherence, it is important to know what factors may affect it, and several studies address this issue. Among the most noteworthy are issues related to mental health, risky sexual practices, substance use, on being men who have sex with men itself. To study HIV-related stigma, there are different proposals. One of them is that one of Ersham and Chaudieu, who proposed that this stigma arises from through three mechanisms. On the one side is the enacted stigma, which refers to all experience of discrimination, social rejection, and differential treatment for living with HIV. By constantly experiencing situations of this type, people living with HIV may internalize certain beliefs and prejudice associated with this infection, referred to as internalized stigma. And having internalized these ideas, people living with HIV may even expect to receive a stigma from others and consequently carry out various coping strategies. This is best explained by Turing's model of minority stress, which builds on Major Original's model to explain that impact of HIV-related stigma to treatment adherence, and mention that this relationship is mediated by dysfunctional coping strategies, such as interpersonal factors, for example, non-disclosure of HIV status, the substance use, mental health issues, and stress process. With this context in mind, we can see that the control and care of HIV epidemic in Mexico is still a pending issue. And research conducted outside of Mexico shows that the substance use, specifically the methamphetamine use and the HIV-related stigma, are associated with the presence of depressive symptoms, risky sexual relations, and evidently lower adherence to treatment. Unfortunately, the research on this topic in the Mexican population has been done only from qualitative perspective views, or only focuses on the study of perceived or anticipated stigma. Therefore, we aim to identify the relationship between HIV-related stigma and adherence to treatment. This among men who have sex with men who used crystal meth in the metropolitan area of the Valley of Mexico. This study is one of the first analyses that we present as part of the PAPID IA 3320 project, which was an exploratory study of crystal meth use among people in Mexico City. The inclusion criteria for this research were living in the metropolitan area of the Valley of Mexico, being 18 years old or older, not being in treatment for substance use, and reporting use of crystal meth in the last 3 months. The inclusion criteria for this research also included being cis men, having sexual relations with another man once in a lifetime, and reporting a positive HIV diagnosis. Regarding the methodology involved, participants were obtained from a non-probabilistic online snowball sampling that was initiated by non-governmental organizations that had contact with people who use substance or who belonged to sexual diversity. And participants were also obtained from the Clínica Especializada Condesa, which is a health institution that offers comprehensive treatment to people living with HIV. Participants were also contacted by men who have sex with men's contact applications, such as Grindr, and other general use applications such as Facebook or Twitter. These participants answered a questionnaire that consisted of several sections, including sociodemographic characteristics, questions related to adherence treatment, HIV-related stigma, condom use, number of sexual partners, the use of crystal meth in the sexual relations, and risk associated with substance use. The analysis of this data involved the use of measures of central tendency to observe the distribution of the independent variable in the sample, and to analyze their sociodemographic characteristics. Bivariate or multivariate logistic regressions were performed to identify what was the relationship between treatment adherence and the HIV-related stigma, of course, controlling for the simultaneous effects of other variables. It is worth mentioning that the Ethics Committee of the Facultad de Psicología of the Universidad Nacional Autónoma de México approved this research. And concerning sociodemographic characteristics, the majority of participants reported having been affiliated with a medical service, having a marital status of single, having a monthly income greater than the Mexican population median, having a higher education level, having a gay sexual orientation, and a contact job as a main source of income. It is only curious that the majority of adherent participants reported having been affiliated with a medical service, while the majority of not adherent participants reported not having had any affiliation with medical service of this type. Concerning the HIV-related stigma reported, there was a tendency for non-adherence participants to report a higher degree of internalized, enacted, anticipate, and total stigma than adherence participants. About condom use, no difference were observed between adherence and non-adherence when comparing the scores with the total sample. But it's important to note that while the majority of participants reported not having had condomless sex with someone they suspected or were certain was living with syphilis, hepatitis C virus, or some other sexually transmitted infection, the majority reported having had it with someone who was possibly living with HIV. According to the number of sexual partners, there is a likely tendency for non-adherence participants to report a greater number of sexual partners than adherent participants. And regarding the use of crystal meth in sexual relations, no difference were observed between adherence and non-adherence, but it was observed that non-adherent participants reported a higher frequency of having received or given crystal meth in exchange for a sexual encounter than in adherent participants. Regarding the risk associated with substance use, the sample in general, regardless their treatment adherence, reported a low and medium risk associated with substance use. But concerning crystal meth, it was observed that the percentage of non-adherence participants who reported a high risk associated with the use of this substance was higher than that of adherent participants. Finally, The factors found to be associated with non-adherence to treatment in the bivariate logistic regressions were the total HIV-related stigma, the enacted, internalized, and anticipated stigma separately, having had a progression of HIV diagnosis, uh, receiving and giving crystal meth in exchange for a sexual encounter, and the risk associated with crystal meth and cocaine use. Subsequently, when different multivariate logistic regression models were performed, the model that showed the best fit for explaining 50% of adherence to treatment in the sample and the KK information criteria states that when controlling for sociodemographic characteristics, participants who reported a higher degree of stigma and high risk associated with crystal meth use were more likely to report non-adherence to treatment. Contrasting the results obtained in this research with previous studies shows that there is indeed a relationship between stigma and adherence to treatment. And as Turan explains, this relationship is possibly mediated by dysfunctional coping stages. That is, anticipated stigma is related to non-disclosure of serostatus, and research conducted in Mexico reported that participants who concealed or did not disclose their serostatus to people in their close social circle had a lower risk of reporting treatment adherence. On the other hand, internalized stigma represents an additional barrier to the disclosure of HIV status because these stigma mechanisms cause that people living with HIV to exclude themselves from social relationships, distort the perceived social support, and increase the interpersonal attachment anxiety. On the other hand, it has been observed that enacted stigma is directly associated with lower adherence to treatment, and that this relationship is mediated by lower self-concept, the presence of depressive symptoms, and substance use. Concerning the substance use, it has been observed that having a substance use disorder implies lower adherence to treatment. However, a differentiated impact has been observed with people reporting using stimulants such as cocaine and crystal meth. Additionally, previous studies have reported that crystal meth abuse particularly affects neurocognitive processes important to adherence to treatment, such as attention and verbal memory. And adherence to treatment in this population could be most affected by the strong impact of crystal meth in the psychosocial domain. Um, Concerning condom use, it was not found to be associated with treatment adherence, possibly because crystal meth use has been described as a strong predictor of inconsistent condom use and marathon sex with multiple partners. However, it is important to mention that while the majority of the sample another regardless their treatment adherence, reported not having condomless sex with someone who had hepatitis C virus, syphilis, or another sexually transmitted infection. They did have sex with someone living with HIV, which tells us that participants are using their seroclassification in terms of looking at the risk of having sex with someone who, for example, has syphilis but not with someone living with HIV, without considering the possible reinfections and therefore the public health implications of this. Neither the number of sexual partners nor the use of crystal meth in sexual relations was found to be associated with treatment adherence. This tells us that possibly the public health interventions to address this issue should not be done in terms of providing these behaviors, but rather should focus on reducing the risk and harms associated with these behaviors. Um, and finally, transactional sex was found to be related to treatment adherence. However, there is not enough evidence to explain that might be mediating this relationship. So qualitative study will be needed to a future study in this finding. In conclusion, it was found that when controlling for sociodemographic variables, those who reported a high degree of stigma and high risk associated with crystal meth use were more likely to report non-adherence to treatment. And these findings show us that the importance of contemplating the stigma and risk associated with substance use in the care of men who have sex with men living with HIV to UNAIDS accomplish the 95-95-95 goal for 2025. And to achieve this, it is recommended that health personnel be trained in basic issues related to HIV, such as the real mechanisms through which HIV is transmitted. And I'm not only referring to public institutions that specifically serve people living with HIV, such as the Clínica Especializada Condesa, but that this information reaches any health professional from the first to the third level of care. Since precisely because of stigma, a person living with HIV could require care and will not ask their doctors for it so as not receive some kind of rejection or discrimination for his or her part. Um, it is also important that health personnel consider the empowerment of patients when choosing a treatment, since it must respond to each person's specific needs. And to achieve effective communication, this should be mediated from assertiveness and even the inclusion of neutral or no sexist language. Likewise, in those cases in which patients use substance recreationally, it will be important not to consider abstinence as the only goal, as this will imply an imposition that does not respond to the needs of the gay populations, such as men who have sex with men. It is therefore imperative that new interventions arise that contemplate risk and harm reductions in terms of substance use, but also in terms of sexual behaviors. Additionally, to meet these objectives, it was important to detect specific needs, especially when talking about K populations, and the establishment of goals and objectives is made from this empathic listening and a mutual agreement between the health professional and the patient. Finally, we would like to propose that in the care of all patients, not just people living with HIV, but in general, health professionals promote the autonomy in terms of the freedom patients have to manage their pleasures, of course, including the self care. Before concluding this presentation, we would like to thank all the people and non governmental organizations that helped in the data collections, as well as the PAPID projects IA 3320 and IA 301422 for the grants received. Thank you very much.